Hi everyone, and welcome to the next session of what is already turning out to be a really interesting and enthusing day. This is a session based on three premises. So what you'll be getting from this session is an understanding of improvement and performance and how they fit together. Three specific objectives I hope you'll be anticipating. One of them is understanding and helping shape a more effective people-centered approach to achieving performance objectives in our sector. Secondly, exploring what a collaborative improvement approach would mean in practice for your teams and organizations. And thirdly, coming out of this session feeling more confident about making the case for participatory improvement methods as a credible route to achieving performance objectives in a sustainable way. So that's the aims or the objectives of what we want to achieve. In terms of who we are and what this, the individuals who will be joining you for this session, I'm delighted to introduce the panel who will be kind of leading the session for us today. For my part, my name is Hesham Abdalla. I'm a consultant paediatrician and head of quality improvement in Oxford, and where my team fit pretty much on the interface between improvement and performance. So we're working on both big drama improvement programs, but also ground up quality improvement initiatives, not dissimilar to what Mary Dixon Wood was describing in her previous session. And with me, I'm delighted to say, a fabulous a panel to digest some of this information with you today. One of the great systems we have on our SpotMe platform is you can access the bios of both speakers as well as some of the delegates. But just by way of introduction, we have Amar Shah, who is speaking today in his capacity as consultant forensic psychiatrist and chief quality officer at East London Foundation Trusts, where he leads an executive board on quality performance strategy planning and business intelligence. Amar is an improvement advisor and faculty member for the Institute of Healthcare Improvement, teaching and guiding improvers on healthcare systems across the world, and also an honorary visiting professor at the University of Leicester. Alongside Amar, we have John Drew, who I've never had the pleasure to meet actually, John, although he was my predecessor in the role that I currently am in Oxford. But John is now Director of Staff Experience and Engagement at NHS England, where he's responsible for national leadership of health and wellbeing, staff engagement, and leads on the delivery of the People Plan. Prior to this role, he was Director of Improvement and Culture at Oxford, and prior to that, he worked at McKinsey's. And then finally, we have Ruth Glassborow, who I'm personally indebted for as a kind of coach and mentor over the last kind of year or so in my current role, Ruth. But she is now Director of Improvement at Healthcare Improvement Scotland, where she leads on improvement support for health and social care organisations across Scotland to redesign and continuously improve services. Ruth previously led work at the Scottish Government on improving dementia diagnosis rates, post-diagnostic work and other improvements to mental health services. And she had a Master's in Public Administration from Warwick Business School, a Master's in Leadership from Ashridge, and is a Gen Q Fellow. So that's I think what you'll hopefully agree is a really experience-wise, credible panel that we have speaking to you. And I'll finish just before we start with this first session is maybe discussion around just ground rules. And actually, I took away from Hariam's session at the speed networking session this morning, rather than ground rules, maybe a ground attitude that we can bring to the session today. And what I advise or yourselves and me to bring is an attitude of intent to learning. One thing I really liked from the VMI report, the Virginia Mason Institute study, the Warwick Business School study of the VMI supported trusts, some of you will have seen this week, is one particular quote from the Surrey and Sussex Improvement Journey. So the chief exec of that trust, Michael Wilson, described one of the most important features of success in integrating quality improvement into the organisation was speaking well of ourselves, well of each other, well of our organisations, and well of our community. And I thought that was a fabulous kind of principle, both to instill within each of our organisations to improve culture, but also to apply here within this next hour or so that we've got in for us to discuss. So I'll invite on that cue our first speaker. So if I could perhaps bring Ruth in at this point, who will be talking about how improvements can help us achieve performance goals in a better way.
Thank you, Hesham, and absolutely delighted to be here this morning to discuss this really important topic with all of you. So I want to start by talking for a minute about performance goals, as these have tended to get a bit of a bad press in the world of improvement. And my slides don't appear to be moving on. Caroline, I don't know if there's anything you can do there. Thank you. So if I can ask you to think for a moment, though, about either your father, your brother, a relative, or a close friend, and whether or not you would be happy if they were sitting on a waiting list for an important operation for 2 years, whether or not you would be happy if their experience in A&E was an 8-hour wait, whether or not you would be happy if they were a delayed discharge in an acute hospital. And the reality is most performance goals are actually there to drive quality of care. The problem comes, and again, Caroline, I don't think I have control of the slides. I don't know if we can fix that because it will be smoother. Thank you. So the problem comes not because of the performance goals, but the problem is when we pursue them regardless of the wider consequences. So we pursue a performance goal in isolation. We can move on. If I can also ask you to think for a moment about performance management. And again, performance management is a word I know that I railed against for years in terms of improvement. But when I sat and thought about it, I thought, actually, I want to be managed in a way that maximizes my performance. I try and manage teams around me in a way that maximizes their performance. And I think we have all lived with the frustration of a poorly performing team that we're interfacing with, which hasn't been managed. So again, the issue here is not that performance management is a bad thing. It is about how we go about performance management. Next, please. So there's nothing inherently wrong with the concept of performance management. The problem is how we go about it. So apologies, everyone. I was meant to have control of the slides. There's quite a few animations. So Caroline, if I just do a nod, will you then bring the next bit in? And that should get this to work more smoothly going forward. Thank you.
No problem.
So let's think for a moment about the way that performance management tends to be done, the predominant approach across our system, which is about working harder. It's that top down, we've got a goal, we're gonna instruct people to work harder to deliver it. And the problem with working harder is this: it works in the short term. That's why it's so predominant, because it does tend to deliver an improvement in the very specific area that's being focused on. However, we know that longer term, it results in a performance failure, but that longer term consequence is separated from the moment of action, so they're not always associated together. What we would like to see from an improvement point of view is the working smarter, and that's what we advocate as a way of delivering performance results. It's getting in and doing the redesign work that will deliver the performance results. But the challenge here is that in the short term, working smarter actually leads to a deterioration in performance. And this is the dilemma we face in terms of how we get improvement to be the predominant way of delivering performance. How do we close the gap in terms of the wrong approach delivering performance quickly and the right approach taking slightly longer? So we're going to come back to that. But before we do, I just want to put a proposition that what if we stopped arguing against performance management and instead focused our attention on a better way of doing it? What does improvement bring to the table? So the first thing we found in Scotland in deploying improvement against performance targets is It is a brilliant method for building clinical buy-in and focusing limited resources on the most impactful issues. And this works with performance colleagues. Many of you will recognise this framework. Some of you it will take you back. It used to be Will Ideas and Execution. I have found in discussions with performance colleagues, this is a fantastic framework that absolutely makes sense to individuals. And then what we can show is with the QI approach, what we're doing with that first understand stage that takes a bit of time, the diagnostic, is we are building the will amongst the services that need to change, and we are helping them to focus on the most impactful issues. And the top-down approach often fails because it has folk doing the thing that is not most impactful in their system. An example here of where we've deployed it against elective weights, and actually doing that understand phase highlighted 40% of the patients on the pathway didn't need an appointment. If they had just focused on delivering the interventions that were being promoted nationally, they would have missed this major opportunity for improvement. We also know that improvement gives us effective methods for balancing top down and bottom up, so it's not all about bottom up. The old driver diagram is fantastic for giving the interventions that will deliver an improvement, but helping people to pick the ones that are right for their context. Balancing measures is great in terms of that challenge around the single goal pursuit, because you put the balancing measures in place around it. And the model for improvement, as we know, is the best implementation method there is for working in complexity and adapting to local contexts. Finally, improvement builds that capacity and capability for more performance improvement. That's the wonderful thing about this approach. You walk away leaving people able to do more for themselves. So there are about 1.5 million staff across the NHS in the UK, accounting for annual leave and a bit of time training and sick. If each of those staff members was to spend just 10 minutes a week doing improvement work, that's the equivalent to 5,300 whole-time equivalent improvers. If they managed to spend 30 minutes a week, that's 16,000 whole-time equivalent improvers. That is the power we could leverage if we got everybody focusing on the improvement work. And as we're going to hear in a minute, it also enables agency in a world that feels increasingly out of control. But the dilemma we face that we'll be interested to get your thoughts on is if we're going to move from the predominant approach of performance management to one that has improvement at the heart, how do we address this issue and ensure that we're not left with an approach that is being used because it delivers in the short term? How do we close the gap between these two sides? Thank you.
Thank you very much, Ruth. Really provocative thoughts there, really lots of stuff to take away, really interesting kind of frameworks as well, particularly around this perception that kind of performance leading to short-term win but long-term losses vis-a-vis improvement, which often feels short-term loss with a long-term gain. So really helpful thoughts. And I'll bring John in next. If I could invite you, John, to share your slides. John will be presenting on, as we heard this morning, on the kind of technical, but now kind of more the people aspect of change. And I'll invite you, John, to describe that.
Thanks, Hesham, and thanks, Ruth. So I'm going to talk a little bit about what the data shows us from the staff survey, and it'll be a bit of a journey through what initially looks like bad news, but hopefully ending with some good news and some hope about how we can connect improvement activity to some of the performance challenges that the NHS faces. So that's a little bit what I'll be trying to do. Yep. So it might surprise you on a quality improvement type seminar to start with quoting Bob Mortimer, probably not known for quality improvement, but I read his book actually a couple of weeks ago, and this passage really struck me. I don't think it's really about hospitals, by the way, but he has a heart bypass operation. You probably know if you watch Bob and Paul go fishing. He says he quite likes hospitals. They have such a purposeful vibe. And then he contrasts that with his experience. It's his experience, wouldn't necessarily, we would all subscribe to this, but he says in previous jobs he's had in the public sector, he's been struck by the malaise. and the sense that there's no real purpose or direction. Whereas he ends with this phrase, a hospital is a full-on, in-your-face achievement factory. So not everybody here works in hospitals, but I think that that is a broader comment that we could make about working in healthcare. So in other words, we've got the core intrinsic motivation, we've got the kind of core purpose, sense of this being meaningful work built in. And then it's a bit what we do with that, and whether sometimes we then do things that get in the way of that. So I've just put this link in. Sorry, I am controlling the slides, but going a bit too quick. If you needed any evidence for this, there's lots of recent evidence, including during and post the pandemic, that people at work are looking more and more for that sense of purpose or meaning. I see that with my kids, 2 of whom are now in work. And you can see that last data point really is that for so-called Gen Z workers, 70% rank purpose as more important than pay. So that ought to be in our favor, is the starting point. We then have a staff survey that was redesigned last year to align with 7 elements of what's called the people promise. So this is the staff survey in NHS England. And there's a core element within it called staff engagement that we've kept the same for many years. And it is very well evidenced, including from work by Michael West. And when the slides go around, you'll see references to that, to link strongly to quality of care and other outcomes, by the way, like sickness absence and other things. And there's particularly 3 questions there that I want to focus on for you really, which are called involvement, but they're about the opportunity to make a difference in the job, including making suggestions to improve work and actually being able to improve the work. So this could link back to Ruth's previous comment that if everyone were able to spend, say, 10 minutes a day working on things that will make a practical difference, these scores would go up. The headlines then on the staff survey last year is that more people than ever participated in the survey. So that's 638,000 people, which makes it one of the biggest staff surveys in the world. But on a trend that had been increasing in previous years, it dropped quite markedly. So you can see the engagement score dropped. And that was really I would say primarily the cumulative impact of everything that people have been through with the pandemic, but also just the general sense of operational pressure and potentially what's happening in the world at large. This is the bottom point of the bad news, really, that since then, that score has dropped further. So the annual staff survey is open at the moment, but in between, we've been measuring this quarterly through a new approach of replacing the staff friends and family test questions with these 9 questions. And you can see that the score has been dropping quarter by quarter. Within the involvement questions, I would say that this particular question really matters. It's, I'm able to make improvements happen in my area of work. And if you look at that data, the detail of it, the grey area is people that say they don't have a strong view, neither one nor the other. But the 2 blue totals, so people who agree or strongly agree with that question, it's around half, 53% say they can make improvements. And that's actually quite a low score for the staff survey compared to other questions. There are 20% that actively say they can't. And if it helps to think of it differently, that if you scale that up to the whole of the NHS in England, that's about 300,000 people, which is the population of Newcastle. So we've got the equivalent of a major city of people working in the NHS that say they really can't make improvements happen in their area of work. But we know, I think, preaching to the choir, that if they could, not only would that make things better for patients and staff, but we also know that that would significantly increase their sense of engagement at work, which has all sorts of other benefits. The other thing that I've started to look at, and this is definitely not research that would, well, it's not research, first of all. So it's just started to put together 2 different data sets. So engagement on the horizontal axis with a measure in the model health system called pay cost per weighted activity unit, which is difficult to kind of understand in everyday terms, but it's a measure of productivity. So how effective are we at getting work done for patients with the people that we've got? And you can see that as engagement goes up, it looks like productivity also goes up. And interestingly, the two organizations in the bottom right-hand corner are both organizations that are known to have improvement methods built into their organizations. So I think we need to do this more, this kind of link, because it will help resolve the dilemma of, emphasizing that we get results through people rather than by just asking for results, if you like. So the more engaged people are, the more likely improvement work is to be happening, the more likely it is to make changes and introduce innovative practice. And that in turn will mean people are more effective in their work, which translates into productivity. So in other words, if that's what you're aiming for, you would get it. You'd be more likely to get it if you had a more engaged workforce. The research that we have from the organisation that's helping us with our staff engagement, and particularly the monthly pulse survey, is that it can take quite a long time for the change curve in an organisation to recover from the kind of events that we've been through with particularly the pandemic. So this data is taken from other things like mergers and significant organisational change. But in other words, we shouldn't be expecting staff engagement to bounce back as quickly as it fell, at least not on its own. We're going to have to put active work in to get there. And then just two final thoughts, really. There's a question for me, which is now, with the benefit of a kind of great unfreezing moment with the pandemic that's caused us to question things, that's enabled us to be, I think, a bit freer in the discretion that's given locally to work out what to do to achieve a certain thing. So in other words, what was said often of the central bodies is that they were clear on what needed to be done, but they left the how to local discretion. I would really recommend this book. I haven't got long enough to talk about it here now, but essentially his core argument is that we need to move from an organizational system that's more characterized by the competitive market, which is that middle orange ring, to the outer ring, which links to things like the Buurtzorg case example, which is a much more devolved method of management that recognizes that organizations are more like a series of interconnected networks, human networks, rather than a giant machine. And I think this has been brought a step closer by the publication this week of the new NHS England operating framework. I don't know if I can get to that. It's on the next page, which is not moving for me. Yeah, there. So I don't know if you've seen this, but if you haven't, it's published, so you can Google it. All I would say is that if you just look at that for a minute, you'll see words like enable improvement, leadership behaviors, learning and improving, sharing the best. So there is a real emphasis built in here, and the narrative that goes with it, that NHS England and the operating framework for the NHS is moving much more towards an approach that I think aligns with some of the things that we've been talking about already in this session. So I think it's a great moment to pick up on this. And I would hope that this would enable you to feel more like you're swimming with the current rather than against the current, which I think is how it often feels in improvement work. So just finally, to summarize the last page, if you can just put that up. The core messages that I've tried to communicate really is that more than ever, people are looking for meaning in their work, and we're working in an organization in a sector where that ought to be built in. But sometimes we manage to mess it up by how we organize work and the way the local culture works. Equally, if we get it right, staff engagement improves. And I think one thing we have managed to do in the last year or two is establish that that in itself is a key measure of performance. It's not some interesting information on the side. It's a central measure of whether the NHS is being successful in delivering great patient care. And a key part of engagement is the three questions around improvement. So the question, I guess, similar to what Ruth has said that I'd be framing is, what's the right balance between advocating and demonstrating an alternative way, or joining in with what the NHS is doing and saying actually the improvement approach is the way we will solve the performance challenges that we've got. And I think the new operating framework makes that much, much more likely. Thanks, Hesham.
Great. Thank you very much, John. Really interesting insights. And what I'd like to do now is just put the question out to the participants. We've got a real dilemma here. We've got what often feels like a performance culture, and yet, as John's final slides showed, a real intent to use or mobilize and engage staff in improvement and to achieve some of those targets. So what's the gap and what needs to be done to bridge that gap? So I'm going to invite you all to contribute your responses to a poll, which is going to come up in a moment. And the question that we're asking you is, how might we shift performance culture in the health sector? So how might we shift the performance culture in the health sector? And you've got a series of options here in front of you, and it's for you to select up to 3 of those. And we'll be aggregating those results over the next minute or so and inviting the speakers to bring their insights into both your responses, but also perhaps their take on that as well. A few more seconds to answer that if you haven't already.
There's 20 or so people who haven't answered, but the results are starting to stabilise, so we can probably publish the results now.
Great. Okay, so I guess we've got a top 3 there, which makes it a little bit easier for us. So top, in terms of certainly percentages that I can see, help leaders understand improvement. Second at 49 was demonstrate performance improvement in practice. And then just behind that at 49, rethink what we mean by performance. So quite an interesting contrast between those 3. One of those, first one there is work with the leaders. Secondly, demonstrate performance improvement in practice. And thirdly, rethink what we mean by performance. And I just perhaps invite our 3 speakers, if there's any thoughts you had on any of those points, or how does that reflect what your reflections are? Perhaps I can invite you just to maybe unmute and just make your own comments on those.
Perhaps just come in briefly, just to say, yes, I think absolutely we have to demonstrate it working in practice. That's really powerful, and do that in relationship with performance management colleagues. So I think building those relationships is vital. I wouldn't underrate the importance of the measures. I think the measures does matter as well, and making sure that we've got meaningful measures and we've got the right balance in measures around some of the performance targets, I think would help enormously as well. Thank you.
Thank you, Ruth. Amar, maybe if I can ask you to share your reflections.
Yeah, I mean, interestingly, those were the boxes that I ticked to, because I think the first step is really to build belief, and I think that one of the ways to do that is to help demonstrate the benefit of applying a systematic approach to solving complex performance issues, so storytelling, and then helping the people who shape culture believe that this is a better way to approach performance challenges.
Brilliant. Thank you, Amar. Okay, we've had 2 presentations so far from Ruth and John, speaking at a kind of national level around the kind of strategic direction and the advice on improvement. We've got Amar now I'm going to invite to speak, who perhaps working at a slightly different level, perhaps where the rubber hits the road, actually at an organizational level, in an organization which really excels at that. And I think pretty uniquely, Amar, I think your role combines those at an executive level. So I'm interested in what you have to say next, and on the subject of integrating performance and improvement at East London Foundation Trust.
Thanks, Hesham, and thanks everyone for joining the session. Really interesting topic. I don't have any slides, but I do have some reflections on what we've learned in this field. So I'm Amar, I'm a doctor and Chief Quality Officer at East London Foundation Trust, which is a provider of a range of services from primary care, community health, mental health and specialist services to about nearly 2 million people across East London and Bedfordshire, Luton. Our system now is that we apply the same approach and method to quality issues and performance issues and financial issues too. It's a common mechanism for us to work through complex challenges. Although that's not where we began, 12 years ago when we first started learning about improvement and applying it, we started with quality issues. But, this is really about our mental model, our thoughts and belief about how we improve. And, there isn't really a distinction then between operational performance, quality or financial performance. If we have a belief that there is a more sustainable, more involving and creative way to solve our problems, then there's no real conceptual reason why you wouldn't apply it to performance challenges as much as you would to quality challenges. So I guess over time we've built that belief, and it's taken time to build that belief. But 4 years ago we intentionally changed our executive portfolios so that quality and performance were both held by the same person, that's me, and that allows us to then have a single, more consistent approach to improving, no matter whether it's a quality issue or a performance issue. I think some of the things that we have worked through in getting to this point is trying to really get a better understanding of what we mean by performance. That's perhaps the starting point. People have different views about what performance means. It's often viewed as a dirty word, and that's because of people's assumptions and beliefs about what that word represents. For many people, it represents contractual performance, things that you're obligated to deliver, things that are imposed on you, and it doesn't have to mean that. I think we ought to think, what do we really mean by performance, and how do we make performance more meaningful? In the same way that most of our quality improvement work is wrapped around what really matters to people. That should be the starting point for all improvement work. When we think about performance, often the starting point is what matters to somebody else, a goal that's set by somewhere else in the system that we have to now achieve. That's the wrong starting point. So how do we really reframe, restart and co-produce what we mean by performance? We just did this over the period of the pandemic. We looked at our performance, our contractual performance, and said, 6,500 key performance indicators is ludicrous, most of which are activity and process based, less outcome based. So let's start again from a blank slate of paper, and let's see what we would really understand by performance. And we've now reduced that by 65%, and they're much more meaningful things that the clinicians, the teams, the commissioners all agree give a rounded view of performance that we can all aspire towards. The second is, what kind of infrastructure do we have around performance improvement? We've learned that, to do improvement really well, teams and people need close support to help them apply a method, to adopt rapid tests of change, to utilize the tools and method of quality improvement. And actually, we need to create almost a similar secondary infrastructure around all of our improvement work, not just limiting it to quality, but so that every element of our system and our organizations have an infrastructure to support performance and quality and financial improvement, no matter what the topic they want to work on. And so now all of our performance leads are trained in improvement to as deep a level as we might have begun with around people who are supporting quality improvement. Our performance leads are improvement coaches, and they have a real depth of experience and expertise in supporting teams to tackle their performance opportunities. And then I think the third thing we've recognized is not to create unnecessary and illogical divide. We often silo functions, and actually the more integrated you have as a management system, the less you want to have one mechanism for managing finance, another mechanism for managing operations, another mechanism for managing performance, and another for quality. Really, we want to have a much more integrated way to do that. So one of the first steps we took was to look at executive portfolios and board reporting, and really making sure that there was as minimal artificial divides as possible, with a single management system that enables us to assure ourselves and to improve what we want to do. So I guess my main provocations to us all, because we are an improvement community, we have real depth of experience and skill to offer the health and care system is, you know, how much of our improvement work is really pointed towards performance opportunities. It's a question we should probably be asking ourselves. And how would we know how much of our work is actually pointed towards quality issues, performance or finance issues? And really, if we're going to really adopt improvement as a method and a mental model and a way of thinking and being in our health and care systems, we need to be able to improve every aspect of how the organization functions, not just the bits that we think we want to focus on. So how can we help? How can we bring our skills to help? And who could we partner with first in the performance sphere? Who might be a willing test bed for us to work alongside and help them demonstrate the value of applying a systematic improvement approach to solving some really important performance issue? And trying to understand from other people's perspectives what is holding people back from the belief. Often it's about pace. Often it's about not feeling they have the luxury of time to follow improvement. And for us, that should be some provocation about how do we demonstrate really good improvement? Because really good improvement should be much faster than the old approach to problem solving. And actually, often what I see is, you know, a lack of rigor, a lack of pace in our improvement. And those are areas we can definitely get better at as improvers, because then people might see that there is a real utility when we're tackling performance issues using the same method. Thanks, Hesham.
No worries. That's really brilliant, Amar. I mean, really interesting and insightful to think about how to reframe performance, taking it away from being a dirty word to something actually that we aspire to. We have in OUH, one of our kind of weekly tempo events is a QI stand-up every Tuesday morning. And just thinking about that event as a performance moment, you know, and then ta-da performance rather than performance as in what level have you achieved this week is something I think would be really interesting to how do we reframe that. So really useful insights. And I'm going to invite our speakers, so Ruth first and then John, perhaps just to maybe share your own reflections on what you heard from Amar. And whilst you're doing that, please do anyone else in the session, if you've got any thoughts or specific questions you might want to pose to one another or to the speakers, please do so. So Ruth first, if I could perhaps just ask you to share your own reflections.
And part of my reflections would be discussions we've been having across the four UK nations and Ireland as QI system leaders. And the last time we met, we focused a lot on this issue. And there were some common thoughts there. So first of all, every nation is struggling with this. How do we change the approach to performance management so that it has an improvement, long-term sustainability focus? We were discussing we all know across the NHS that the current approach, the predominant approach, isn't effective. So it's part of the solution, more of a bottom-up social movement. It's not going to be one thing, but we were interested in that social movement approach to challenging the way things are done and linking across to that. Is there a stronger role for our clinical governance structures here, particularly around making sure that we have appropriate balancing measures around performance goals? So is there more we could be harnessing through the clinical governance route? How are we seen by performance management colleagues? And we had a really interesting debate across the 5 nations. What if we were to go and ask some of the folk that we have been struggling with, how do they see us? What do they think the value of improvement is? That might give us some useful insights. And as Amar was sharing there, it is about being able to demonstrate in practice and leaning in. And actually, I know when we started the work in Scotland around QI into elective weights, I had at least one senior QI leader tell me, don't go there. We don't want to get tarnished by the performance management culture. If we don't lean in on performance issues, then I think we are not doing what we should be doing. And we are failing in our duties around improving the NHS because, you know, these are big issues. And then finally, I would keep coming back to this dilemma. The current predominant approach is there because it works in the short term. So it's our improvement mantra. Every system is perfectly designed to get the results it gets. So it is back down to that. How do we shift that approach, which delivers in the short term, but has negative consequences in the longer term? And is there a way of us being clearer about those longer term negative consequences. And we're just so interested across all of the 5 countries about ways we might do that. Thank you.
Wow, that's really helpful kind of thoughts and provocations, Ruth. I particularly like that question really that you posed about, where are we part of the problem here? Is it, because we as improvers are not doing what we could or should be doing, or are we actually sometimes instigating issues and avoiding potential conflicts when we could potentially be resolving them? So, John, perhaps if I can ask you finally to bring in your own reflections, thinking about it either from your perspective of other industries or from NHSE.
Thank you. I mean, overall, I would say that a lot is to do with mindsets and behaviors. So how we actually think and how we behave. We've talked a lot about processes, organizational processes and practices, and they're important too. I mean, I think what Amar described about rethinking what we mean by performance and understanding what gives people the belief that something is possible is actually more about the mindsets. That's a choice we have. So it goes back to this thing of, there's a lot of things you can't influence and you have no control over, but there's certain things that we really can control or at least influence. And one of them is how we respond to the situation that we're in. So in practice, one of the things that I found helpful is just to ask people to reflect on their own experience of being in a team where they felt well supported and really kind of effective compared to a team or an organization that really didn't. And people will normally say it's like an order of magnitude different. Your performance and what you're able to contribute, it's not like 5% better. It's kind of 100% better. And yet the NHS struggles to deliver 1 or 2% improvement a year. So there's something that doesn't compute there. And most people here will have been involved in improvement activity, probably are day to day, where you see kind of improvements of, 30, 40% in certain metrics. So what's happening there, I think, is that we're imposing a model on an organization that actually isn't even true in our own experience. That's the weird thing. So we sort of persist with an approach that if we reflect about how does that work for us personally, our experience is it hasn't been particularly motivating. It doesn't cause us to give the best of what we have. Part of the dilemma then is the people that, I'm going to make a big generalization here, but the people running organizations have got there by being successful in the current model. So you're asking quite a lot of them to say, please, would you take a risk in, giving up or trading in some of what you know how to do that's got you here to try something that you don't know whether it's really going to work. And so I think we have to put ourselves in their shoes a bit to be a bit more sympathetic, which is what would cause people to take that kind of risk. It could be insight, but it's often seeing it somewhere else. It's often an emotional reaction to a real crisis. Like, Virginia Mason started because of the avoidable death of a boy. I think I'm right, Amar, that in East London, there was an incident where one patient murdered another some years ago. And that caused people to say, we just can't, we've got to do something different, or there's a level of emotional interrupt to what's going on. So I would encourage us not just to frame it as a wholly rational organizational type thing, but to recognize that in the end, the people leading organizations are human too. Another thing, by the way, that could help is desperation. People are more willing to take a risk if they're really stuck. And I think increasingly with some of the performance challenges of the NHS, we are quite stuck. So I think to be able to come and say, look, I can help you here and give some evidence that it works, I think people are perhaps more likely to engage at the moment than they might have been before. And then last thing I would say that there is some of it is just timing. We've got by accident a chancellor at the moment that is the longest serving health secretary that has recently written a book about how the NHS is stifled by Stalinist targets. As far as I can tell, he's actually running the country at the moment. I mean, that could actually be quite helpful. You've also got, I think, a leader in Amanda Pritchard, who's also come from a background of leading and running NHS organisations as a COO and a CEO. And I'm sure that's partly why the operating framework is kind of much more human, is that her experience is actually that's what will make the difference. So sometimes I think this is about, is the moment right? And I don't want to be too optimistic because it could lead to disappointment, but I think there's something changing at the moment where the conditions might be more likely for this to really become normal as opposed to be the kind of minority sport that happens alongside you know, the main event and the predominant orthodoxy, if I can put it that way.
Brilliant, John. Really interesting and helpful insights. So what we have now is a precious half an hour that as a group to reflect on some of the material that you've heard in breakout groups. And what we'll be inviting you to do in those sessions is to address a question really about how does some of these ideas and these provocations apply. The question that you'll be invited to consider are the three that are on the slides now, which have just appeared. So how far does your organization incorporate improvement principles and approaches into how critical performance goals are achieved? So this is a reflection on your own organization, the context in which you're working in, and actually how does improvement integrate within performance? Secondly, what do you think gets in the way? If there is a gap, what is the cause of the gap? And the third and perhaps most intriguing question is, what can we as a tribe of improvers collectively and individually do differently to shift that? So you'll be whisked away in a moment into groups to discuss those three questions, so 25 minutes. And I really invite you to spend that time trying to understand and think deeply on these critical performance and improvement dilemmas, which I think are certainly part of my daily practice, but I think would be really helpful to have the headspace and the opportunity to reflect with like-minded individuals on that discussion. Great, welcome back everyone. Nice to have you back in the main room. Okay, we have about 10 minutes or so left of this session, and this is an opportunity for you to share back briefly from each of your groups what it was that you discussed in those sessions. And you can do that in the chat, but if you're ready to do that now, just put your entry points, or if you have something more specific you might want to share or a question, you can raise your hand, and we can perhaps invite a little bit of discussion on that. But if you could, as a starting point, put any of your comments or discussion points into the chat, that would be a great starting point. And whilst we're doing that, I noticed the panel members were also in the group sessions. If perhaps you might want to share your own brief reflections of your experience in those groups. If I can invite Amar, Ruth, or John to just bring your own conversations into the session.
We talked about how some of the most important outcomes are often very hard to measure. So the example in our case was about psychiatry, but potentially that creates an opportunity because you can do some work locally. But then we also talked about how in the end this needs to be scaled up to really kind of make a difference. And three of us on the call were involved in kind of national roles or national bodies. And I guess we were also quite honest and said you learn to measure progress in different ways, because it's going to take time. I mean, I think that's the thing. It's very unlikely that there'll be a mass collective like flash of insight and it all changes overnight. So I think in those roles, and for many of you, it's about being patient and waiting for opportunities. And when there is an opportunity, to then weigh in at that point to try and influence things. And sometimes the opportunity will present as a kind of a problem, a crisis, an unsolved thing. But it's about what are the moments that you can intervene for maximum effect, I suppose.
Brilliant. Thank you, John. And before I bring Amar in, I just again encourage you all to put your kind of comments and summaries into the chat. We'll be collating all of this information, and the Q team will be using this as part of their evaluation. So there'll be lots of learning through that shared kind of knowledge, I think, that if you were to do so. Perhaps Amar, if I could perhaps maybe bring you in next.
Yeah, no, really good conversation, and similar to John, actually, that the recognition that this is a long game, things are unlikely to change rapidly, and what we as improvers can probably do is just recognize what's within our influence and what's within our control, and start to demonstrate the value of improvement in areas where we think there's an opportunity. It's not going to be straightforward to suddenly transform all of our approach to performance challenges, but there might be one or two areas of performance where there's less risk for the organization in giving this approach a go. And maybe there's one sponsor, one senior leader who might be willing to support this approach and be able to shield the organization whilst it experiments with this approach. So thinking really about what could we do? But I think the other side of this conversation was really making sure that the language we use and how inclusive we are, we need to consider how we open up our world beyond people just living in quality, and at the same time not losing the rigor and the pace with which we do improvement, because that's really, if we can demonstrate really good improvement work, I think people will see the benefit.
Great, thank you, Amar. And then finally, Ruth, if I can invite you to share your own group reflections, please.
Thank you. Similarly, a great discussion, and similar to the other two, actually. This is a difficult, complex issue. It's not going to be fixed quickly. It's about making progress as we go. We did talk a bit about the advantages of seeing data in the round, of bringing the performance, quality and financial data together. And I'm hoping that Haider is going to share in the chat box a link to work that he's done that has brought data together, that apparently has been really helpful in terms of trying to shift some of the discussions on. Thank you.
Great. He looks like he's just done that as well. So thank you for that, Haider. We've got a few more minutes, I think. So if there are any other comments or reflections people might want to share, do put your hand up and we can perhaps bring that to the round. Some really interesting insights in the chat there. I think there's going to be lots that we can take away and hopefully kind of digest and use as part of our own evaluation and to share some of that learning. Okay. Well, what we'll do then in this case is we'll close, and I'd like to start by thanking the panel who have brought
Hesham, you did have, there was a Pete there. Pete, that's
Oh, okay, sorry, who was that? I didn't quite catch that, Penny, is that?
Pete, I'm sorry, I don't know how to say your surname.
I think that's fine.
Yeah,
no, it's fine. I was only gonna comment. I mean, I'll put stuff in the chat, but I just think the conversations, it was just amazing how much our experiences were the same, completely, different organizations, different roles in the NHS or working alongside the NHS, but that experience of lots of great work, I suppose resonating with what Mary said, lots of great work happening, but not in a very well-led and coordinated way, and lots of, I guess, silo working, which I think is maybe some of that's just the way that the NHS has evolved and things being bolted on to another thing rather than that high-level view. So I think there was a lot of shared experience in that, which was
which in itself is a really valuable insight, Pete, actually, in terms of understanding actually that there are so many things that we do have in common, and therefore presumably shared approaches that we can use to try to address those. I think is a really important and actually very impactful point. John?
Yeah, I suppose I just want to encourage people in a way. I mean, I suppose I've been wanting to do this kind of work and have been one way or another for maybe getting on for 30 years. And I suppose as you get older, or as I've got older, my dad likes to say, as you get older, you exchange energy for wisdom. So whereas I might have charged in a bit or got frustrated more, I think I have come to see that a lot is about timing and waiting for opportunities to present themselves. But I think there is another thing, because that's maybe not a very encouraging message to say, just kind of sit tight and it might get better. The other thing I would say is take the initiative. And my experience, including as a senior leader, is if somebody comes to me and says, I want to do something, I then feel naturally that I really want to work quite hard to help this person do the thing that they want to do, provided, and in most cases, it will be in line with what the organisation is trying to do. So, I would encourage you in a way to take a bit of a risk, maybe take the initiative, approach a senior leader that you get the sense gets this, and either ask for help or make an offer, because both of those things, asking for help and making an offer, tend to provoke a positive response. So, you know, I would encourage you to challenge yourself a bit about what's stopping you taking a bit of a risk, and how much of a risk really is that. You know, the worst thing that can happen is they say, well, thanks, but I really don't have the time to engage on that. But I think most senior leaders won't do that. So that can then open things up a bit more. Don't wait for it to happen to the point that you're not taking the initiative yourself, I suppose.
Yeah. Really helpful insights, John. I remember kind of reflecting back when I was a junior doctor, I used to have this fantasy that there'll be a point where I'll be senior enough to be able to make things happen. Whereas actually what it clearly is needed is those energetic people as well as those wise people working in collaboration, which is great. And I take a final comment from Penny, please.
Yeah, I mean, just building on what John was saying, one of the things that we were talking about in our group was how sometimes as improvers we can kind of actively avoid getting focused on the kind of must-do performance priorities. I know personally I've sometimes tried to, I recognise I've kind of consigned myself to the margins in organisations and done kind of nice, neat improvement projects, because actually when you get pulled into the things that have big cost improvement objectives tied to them, then you can make a change in a small area and suddenly people can assume you'll generate cash releasing savings, for example, you know, or you can do something which is still at an early stage, and people can get excited and then want to roll it out more quickly than they're comfortable doing. You know, or equally you might be held to expectations that are unrealistic. So I think there's all sorts of things that, you know, scars that we hold as improvers that can make us a bit hesitant about getting in there on some of the kind of higher stakes performance work. But I'm wondering now whether actually, as you change and move roles, like there are places, as John says, where you can think about a different kind of conversation about kind of really focusing on some of the higher stakes objectives. And try not to be haunted too much by that previous experience that might have stopped us, you know, using our own power that we do have.
Yeah, thank you for sharing that, Penny. So thank you all, both the panel and for the people who attended and shared your own stories, reflections and insights, and some of those will be certainly taking away. I'd like an opportunity for you to complete some evaluation on the session, if you wouldn't mind, before you leave, and you'll get a link on the screen to be able to do that in a moment. There's also the opportunity to continue with the conversations in Leeds and Bristol next week, which for those of you who are going to the face-to-face sessions, I'm looking forward to the Leeds one certainly. You know, it's been a while since I've been to a face-to-face conference. I'm really looking forward to networking with my tribe of improvers. The New Insights project that you heard about briefly from Mary this morning, there's an opportunity to register your interest in that, and that's a really exciting project, which will, I'm sure, make a difference in many of the areas that we've been discussing this afternoon. And then finally, I invite you to enjoy your lunch. There are some well-being and yoga sessions that you can book into, some meditation session as well, which is, I think, what I've earmarked. And I look forward to seeing you all back here at 1:45. And thank you very much for your contributions, and look forward to seeing you again.